not very frequent, but as you see, as I said earlier, 2 times more mortality as compared to the reference range. So both low glucose and high glucose are important as adverse prognostic vital signs. And you as clinicians, I don't need to remind you what this vital sign may be associated with in severe hypoglycemia, both in type 1 and type 2. You get in about 50% prolonged QTC, which is always serious signal for the patient, hypokalemia, and also hypertensive crisis is very, very common. So this is the unhealthy context of hypoglycemia. So somehow it's reassuring that this particular study has looked at whether iatrogenic hypoglycemia via insulin or hypoglycemia without insulin therapy is more detrimental. And the good news is the hypoglycemia in this study related to insulin does not really show increased risk. And they also could exclude coexisting oral hypoglycemic drugs, of course, mainly sulfonylureas, that this is not really the reason. So the most likely explanation for the findings is this is a marker rather than a direct mediator of higher mortality in this setting. Now we're still struggling with the problem, what about when we target the glucose in this setting of acute conditions? And you're looking here at studies with an aim 70 to 110 milligrams of glucose, so rather ambitious. And a very clear message comes out of that. Mixed ICU, medical ICU, no benefit. And in the surgical ICU, mainly due to much less infection and much better wound healing, there is a significant benefit of around 40% reduction of mortality. I think those people were lucky because at the same time, it's also clear that the risk of hypoglycemia went up by 6 times. So this is really a very important consideration. Now, for the time being and waiting for more studies, this is what we currently recommend. Be much more modest for the glucose range here. Very little glucose. There have been really disasters with too much glucose. And what is very important, the insulin infusion has to be strictly separate from any other IV infusion. You need to dose it right as suggested here. And of course, you also need to consider potassium in this context. Now, for a moment, just keep in mind, it's not a problem of too much glucose going into the cells. It is due to the excess of fatty acids being used here, doing all the negative things here. So what is important is we have to stop the usage of fatty acids in this context, which to some extent, of course, is driven by counter-regulatory hormones here. Now, you may have then the question, is it actually possible with this counter-regulation to diagnose diabetes in this context? And there's a very clear message. If you do it after stabilization, after doing angioplasty on the 4th day or so, on the time of referral to standard care, yes, you can. You see here, sorry, that, my goodness. I'm wasting my time here, that if you do that, you pick up a lot of undiagnosed diabetes, but there is a minority only with normal glucose tolerance. If you do this, the same patient 3 months later, there is no bouncing back to normal glycemia. There is some shift from overt type 2 diabetes to IGT, and also 1 year later. So yes, it is possible. You pick up a lot of undiagnosed diabetes, some 50% of diabetes in conjunction. And the important question could be, what about the use of A1C to make life easier? And this is very important information. A1C is not helpful in this large population of over 4,000 people. See, the least yield you get with A1C measurements, 75% you pick up with the fasting plasma glucose, another 40% with the oral glucose tolerance test. And there is the question of some misclassification, because those people up here have normal glucose values, so they may have a problem with anemia or other hemoglobin abnormalities. So this is important for daily care. Now, in the chronic state, there now has been the concept of the glycemic pentate. It's not just A1C, fasting plasma glucose, postprandial glucose, glycemic variability, and hypoglycemia, all contributing to the outcome in those patients. Now, I think this is one of the current problems. We are focusing very much on A1C and losing sight, perhaps, on other very important components. So it's probably not that much surprising that we are a little bit disturbed by the outcome of all these randomized intervention trials. I've listed them all, and actually UKPDS was a study targeting fasting plasma glucose. The A1C was introduced only later on, so maybe there's also a message there, and it's certainly premature to make a final judgment, but also keep in mind, this was in the pre-statin area, so maybe without the context of statin, you get other results. And since we have largely statins, and this wonderful talk we just heard, in the trials, up to 80-90% are on statins. We don't have really seen positive trials here. Now, Pablo Aschner will discuss this later, but I would like to carry it a little bit further. And this is really big data, 500,000 patients in more than 100 studies. And here you look at vascular death in relation to mean fasting plasma glucose, and you see what you expect. But not only that, if you look for a cancer death, a very similar association emerges, and even for non-cancer, non-vascular death, a very similar association emerges. So this tells us there must be something beyond with this glucose at the fifth vital sign in this condition. And very recently, there's good continental analysis from Australia telling us the cancer incidence in type 1 diabetes, which is a much more pure hyperglycemic situation than type 2 diabetes. And you find liver cancer, pancreas cancer, also esophageal cancer, and all the other known things very similar as in type 2 diabetes. And this is cancer mortality. So the concept is glucose in this as a vital sign never walks alone. We have to keep in mind, we heard earlier about the waist circumference hypertriglyceridemia aspect. It is usually related with inflammation, pre-thrombotic rate, insulin resistance, and cancer. Those are very important factors out there. Now, a very interesting new way to overcome those problems of observational studies is doing Mendelian randomization analysis. So you remember 150 years ago, Gregor Mendel described how all these genes are given to the next generation. And what you can do now is in relation to diabetes. There are more than 60 genes known, SNPs, associated with diabetes. And then you can go back and ask, are those genes also associated with concurring coronary artery disease in those more than, I think, 300,000 patients out there? So this gets rid of the potential confounders and the problem of reverse causation, which may be, for instance, with hypoglycemia, where other conditions induce the hypoglycemia. Now, this is interesting in terms of the association also with coronary artery disease, you look here the impact of fasting glucose, the A1C, and diabetes. And then you can go ahead, and there are also, of course, genes related to LDL, to the blood pressure, to BMI, in order to stratify for all those coexisting conditions. And at the end of the day, actually, you come up that there is a significant increase, making it likely that this is a causative thing. You can do the same thing with cancer. There are also, of course, many genetic factors in that. And down here, you're looking at the contrast between observational and this genetic Mendelian-driven studies. Now, with that, I'm hoping to be in time. Glucose as the fifth vital sign, my conclusions. Very important in diagnosing diabetes-related emergencies, but other context. Very important in predicting in-hospital mortality, but also longer-term mortality in patients with acute coronary syndrome, stroke, other serious conditions. Both low and high glucose are important adverse prognostic vital signs in patients with serious acute disease conditions. And targeting and treating glucose levels in patients with such serious acute disease conditions should avoid harm first and aim only for modest control. Important also in context with serious chronic disease, predicting CVD, cancer, all-cause mortality, but maybe only at the tip of the iceberg, referring to many other risk factors underneath. And genetic Mendelian randomization analysis may be an innovative way to look into a causative role of glucose as a fifth vital sign for serious chronic disease. Now, before ending, I could not really resist that to recur. Here we are in India, the country of 300 million gods, I have been told. And one very important god is the sun god. And I found this in one of the hotels I was staying in. And as you see here is, it is supportive, or supposed to be supportive, if something is wrong with your glands in your pancreas, and perhaps also with glucose as the fifth vital sign. Thank you very much for listening.